This is a video about peripherally inserted central venous catheter PICC in neonates from Evelina London Children's Hospital Neonatal Unit. Peripherally inserted central catheter or PICC is a device that enters through the skin directly into a peripheral vein and subsequently reaches a central vein. That could be the superior vena cava or inferior vena cava. Objectives of the learning will be to provide current evidence, indication for PICC insertion, equipment available and preparation, insertion technique, appropriate aftercare of the line, and complications associated with PICC. Current evidence for PICC insertion have been reported by the CDC in 2011 and the NAN report in 2015. This includes 10 main points for action. First, all neonatal staff involved in the insertion and ongoing care of PICC must have received training appropriate to their grade in this procedure. Using a central line bundle, which includes all the next points. Hand hygiene, maximum barrier precaution upon insertion, cap, mask, sterile gown, sterile gloves, and one large fenestrated sterile drape. Use chlorhexidine 2% in 70% isopropyl alcohol for skin antisepsis and dressing change. Use 2% chlorhexidine in 17% isopropyl alcohol wipes with every connector access. Optimal catheter site selection. Use of a catheter insertion checklist and a standardized protocol for central venous catheter insertion. Daily review of line. Necessity with prompt removal of unnecessary lines. Using standardized protocols for maintaining PICC lines. Indication for PICC line insertion. Parenteral nutrition for premature infants, specifically low birth weight infants. Infants requiring more than 6 days of IV therapies, which may include those with infection, gastrointestinal disorders, respiratory insufficiency, congenital or acquired renal insufficiency, and congenital cardiac disorders. Limb anomalies, which may limit the number of vascular access sites. Delivery of irritant medications. Administration of continuous drug infusion, such as vasoactive, inotropic, sedation, anticonvulsivants, and metabolic drugs. In our units, the main indication is to deliver continuous infusion of prostin. Contraindications and considerations. Infection of the inside of insertion, severe coagulopathy that is not an absolute contraindication but might require blood product prior to procedure. Active bloodstream infection, non-thrombus in the selected vein, if vascular access can be achieved with a peripheral or midline catheter. Preliminary steps. Inform parents and explain procedure. Discuss all planned procedures at the huddle so a time can be set for each of them, ensuring availability of the necessary staff. Long line insertion is a two-person procedure to ensure maintenance of the sterile field. The procedure may not go ahead without the presence of an assistant. Begin the long line insertion checklist. Identify the site for insertion. Equipment should include hat, mask, sterile gown, and 2 pairs of sterile gloves. A vegan PICC insertion pack containing a 2 French Nutri-line already inside, 1 measuring tape, 1 outer wrap, a peelable cannula, a 10 ml syringe, a fenestrated drape, 1 gallipot, 2 ball swabs, and 1 sponge stick. If indicated, a Premicat or a twin flow catheter. Chlorhexidine 0.5% or 2%, depending on the term and the postnatal age of the baby. A large sterile drape. Sterile saline 0.9% for injection. Duoderm. Sterile gauzes and a needleless connector. For skin antisepsis, chlorhexidine 2% with 70% isopropyl alcohol or chloroprep should be used for all babies, except for babies who are less than 30 weeks gestation and less than 2 weeks old. In that case, use 0.5% aqueous chlorhexidine. Choosing the appropriate line. Nutriline is a 2 French single-lumen 30 cm line. It is the first line catheter inserted. Omnipac is not required to visualize the tip line position. Premicat is a 1 French single-lumen 20 cm line. It is indicated for babies less than 800 grams and for babies with difficult access who have had multiple attempts with a 2 French line. It does require Omnipac for visualize the tip position. The double lumen Nutriline is a 2-1 French lumens 30 cm catheter. It is indicated for babies requiring TPN and Prostin. It does not require Omnipac. Commonly used insertion sites are the arms, legs, and scalp. The veins of the hands and feet are other possible sites for neonatal PICCs. The basilic vein is larger and less tortuous than the cephalic vein. The right basilic vein is preferred over the left basilic vein because the right vein has a more direct route to central circulation. The axillary vein is large and provides a direct route to the subclavian vein. Be careful to avoid cannulation of the axillary artery. Leg veins offer multiple sites for neonatal PICC placement. Consider the right saphenous vein in initial assessment for catheter placement unless gastroschisis is present, as it is associated with lower malposition rate. Advancing the catheter at the level of the femoral fold can be difficult. If distal vein catheterization fails, scalp or more proximal veins can be used in distal to proximal sequence. Scalp veins are easily visualized but may become tortuous at the level of the ear and on entrance to the subclavian veins. Moving the patient's head to a midline position during insertion may facilitate catheter advancement to the central circulation. Measure length between site of insertion and optimal tip line. For upper body insertion, measure from the insertion site along the course of the vein to the right of the sternal border to the third intercostal space. If insertion is through an arm vein, extend the arm at a 90-degree angle for measuring. For lower extremity insertion, measure from the insertion site along the course of the vein to the right of the umbilicus and up to the xiphoid. Position and swaddle the baby, leaving easy access to the identified site. Provide developmentally supportive care and comfort measures prior to and throughout the procedure. Use pacifiers, containment, positioning, gentle technique, non-nutritive sucking, and sucrose or breast milk as appropriate. Ensure babies in giraffe incubators are on baby mode, and consider adding a bar of heat for babies in baby therms. Ensure your assistant is available and ready for the procedure to begin. Wash hands using aseptic hand washing technique. Put on a sterile gown and 2 pairs of sterile gloves. Have an assistant open sterile equipment. Place sterile drape over trolley and lay out all equipment. Don't open the catheter initially. Cleanse the whole limb with chlorhexidine 0.5% or 2% in 70% alcohol, depending on term and postnatal age. Apply the solution for 30 seconds and allow it to dry at least for 30 seconds. Drape the baby with a large fenestrated drape, covering the baby as well as the whole incubator environment, exposing sides only. Keep the face of the baby visible and always accessible to assistant. Remove gloves after setting the drape and before preparing the catheter. Open and prime catheter lumen with 0.9% sodium chloride to check catheter patency. Leave the 10 ml syringe on for flushing, air removed from the syringe, to avoid air embolism. Occlude the line with the white plastic clip. Check the line can pass through the cannula. Insertion. Puncture the vein with the introducer needle and observe for blood return. Stop advancing the needle as soon as there is blood return to prevent puncture of the posterior wall of the vein. When using a peel-away sheath, withdraw the needle and then insert the catheter through the introducer to the appropriate pre-measured location. The catheter should advance with ease. Once the catheter is properly located in the inferior vena cava or superior vena cava, blood should return with ease. On a patient, the operator catheterizes the vein, advances until a flashback is seen in the flash chamber and holds the cannula. He then introduces the line with a straight, non-tooth iris forceps through the cannula. Thread the catheter slowly at 1–2 mm at a time until the desired length is obtained. Press the catheter at the site of entry with sterile gauze and withdraw the peelable cannula.
In case of non-peelable cannula, it should be totally pulled out of the patient's skin and fixed to the long line connector. If necessary, press until bleeding stops. This may take up to 10–15 minutes. Secure the line with steri strip and start fixation. Before fixing, always check there is blood flush back and flush the line.
Line dressing. Apply one steri strip just below the insertion site. The insertion site should remain visible so it can be continually assessed. In smaller babies, even short steri strips may need to be cut shorter so they do not lead to a circumferential dressing. Coil the line, applying only the number of steri strips needed to hold the coil in place. Ensure the wings will lay flat or not over a joint. Apply a square of duoderm to protect the skin underneath the wings. Secure the wings using 2 steri strips. Check pump pressures to ensure the line has not kinked. Cover with tegaderm, ensuring the insertion site is well covered and the dressing is not circumferential. Ensure the edges of all steri strips are covered. Apply a chevron over or under to anchor the wings. Secure the line back on itself.
Call for X-ray to check tip line placement and avoid malposition. The distal tip of the central catheter should dwell in the superior vena cava, optimally at the junction with the right atrium for upper body insertion, and for inferior vena cava at the junction with the right atrium or above L2. Aftercare. Access line using aseptic non-touch technique. Minimize number of time line is accessed. Reassess need for central line daily. Repositioning of the line requires a full dressing change. It is a 2-person procedure. It should involve a member of the nursing-led long line dressing change group. Swaddle the baby, leaving easy access to the line. Consider pain relief and thermoregulation. A dressing pack and dressing supplies are needed. Documentation. Checklist should be filled before, during, and after each procedure. Please complete your documentation on Badgernet, in full notes of the day, line, in the plain text area. Complications of indwelling neonatal peaks include central line associated bloodstream infection, occlusion, tamponade, catheter migration, catheter dislodgement, dysarrhythmias, thrombosis, and catheter fracture and embolism. Removal of lines. The removal of any vascular access device requires an aseptic non-touch technique. Complications associated with removal of PICC line are mainly infections and mechanical problems. Line should be removed when it is not required anymore or if there is a suspected line-related infection. In that case, the tip should be placed directly into a sterile specimen container, cutting the tip approximately 5 cm with a pair of sterile scissors and sent to the bacteriology laboratory for microbiological investigation. Vascular access is an important component of the care of the sick or preterm neonate, providing life-sustaining parenteral nutrition and medications. Medical practitioners caring for neonates should be well trained in the skill of neonatal PICC placement and catheter care.